welcome. Let me actually make sure I'm unmuted. I am unmuted. All right, we're going to start PowerPoint. Okay, so I'm going to keep it on this page for those of you that are online because I'm not going to be able to see you, let people in, and move the pages. So this is how it's going to look. I do apologize. This is our first hybrid, but I want to welcome everybody. I want to, I think most of you are familiar with Ruth's House Assisted Living. Of course, it's part of the JGS Life Care Campus of Care, which is a 23-acre campus here in Longmeadow. And I know some of you guys online, even from Eastern Mass, know that we've got the 23-acre campus. You've got Dr. May, which is our on-site physician for Ruth's House, as well as myself. I work for the campus. And then we've got Andrea Bates. Come on in here. She's actually our new marketing director. There's been a little bit of changes going on at Ruth's House Assisted Living, which are very exciting. Christina Tui, who used to be in the marketing role, is now going to be executive director. Andrea is going to take the marketing director role, which is exciting. And then Maddie was here a second ago. She's actually moving to a regional position, which is going to be very, very good for all of us. We've got a couple of other folks. Starlene Warner is our resident care director. Terry Halliday is another regional. She's actually Chief Business Development Officer. And then we've got Susan Halperin, which is our Vice President of Development. So that explains who we are as people. I want to tell you a little bit about the campus itself. Again, it's 23 acres and it's got everything from independent living, assisted living. We've got Spectrum Home Health and Hospice. We have a Warnick Adult Day Health, which is our first adult day health in the area. We've got two different rehabs. We've got Sossin Center for Rehabilitation, which is a greenhouse model of care, as well as we just got Northeast Rehab Associates, which some of you are familiar with. They used to be located in Agawam. They have relocated to our campus. So Sherry's staff and all of her staff are now here. So I'll quickly go over it. Of course, we've got the Levitt Family Jewish Home, which is our nursing home, long-term care, as well as long-term rehab. Sossin Center, which is our greenhouse model of care. If you look at the photo, literally you can see it's like a dining room that you or I would have. We've got pendant lighting, we've got granite countertops. It's absolutely gorgeous. If you've never seen it, let me know. I'd be more than willing to take you over there for a tour. Northeast Rehab, like I said, coming from Agawam, they specialize in orthopedic, they do cardiac, they do respiratory, as well as pulmonary care. Warnick Adult Day Health, again, it's one of the first adult day health programs in this area. And it's good for folks that need, maybe mom lives with them. Maybe they go to work during the day. So they want to drop mom off, or they could actually have them picked up because we have transportation. They could stay there for the day and then they get dropped off in the afternoon. So without worry, you could go to work, you could run errands, or you could even just have respite time for yourself without having to worry about your loved one. Again, Spectrum Home Health and Hospice, it's individualized care in your own home, and home could be an assisted living or an independent living. It doesn't have to be out in the community. It could be part of a community. And then we've got Genesis House. When you came in, you passed it on the, let's see, it would be on the right-hand side. Independent living, it's actually subsidized independent living in Longmeadow. Again, if you've never seen the inside of that, it's absolutely beautiful. There's a reason why there's a 3-year wait list, because it really is as nice on the inside as it is on the outside. And then of course, Ruth's House Assisted Living, which afterwards I would be more than happy to give you a tour. Myself, Andrea, Terry's even willing to give tours today. And it's independent, not independent, it's assisted living plus memory care. And we've got, it's small, it's 70 apartments. So it's very small, it's very intimate, but you've got the higher level of care on the memory program. And if you look outside the window, if you did get a chance, you've got a big garden area out there because we really want to promote outside time. And it's fully secure. Although right now, I am sorry to say that our waterfall is leaking, so it's not running. Usually it's a gorgeous waterfall in the middle, but you'll have to come back when it's working. But I'd be more than happy to give you a tour just to show you around. And if you have any questions, you could ask specific questions about Ruth's House and or any other part of the campus. And with that said, all you. Let me just check in on the Zoom gals. Let me make sure. Can everybody see the screen? Are we good? Thumbs up or in the good? We got a good. All right, perfect. Thank you, Randy. All right, so yep. Dr. May, it's all you.
So good afternoon. I'm happy to see all of you here. So I just wanted to thank Marianne and everybody here at Ruth's house for setting this up. It was really nice, lovely to bring in the community and to be able to talk about such a common health condition that occurs. It occurs in the young and the old, but it's particularly problematic in our patients who are seniors. So it's something called orthostatic hypotension. So hypertension means high blood pressure. Hypotension means low blood pressure. Orthostatic hypotension means that there's a low blood pressure associated with a change in movement. So if you can go to the next slide. So traditionally, when we looked at orthostatic hypotension, what we first saw was that patients were clinically symptomatic from the orthostatic hypotension. So they had either dizziness, lightheadedness, fatigue, they felt like they were going to faint. But now with the revised perception, which you can see, you may not have symptoms. And actually, if you don't have symptoms, it still could indicate that you could be orthostatic. So what I wanted to kind of show you in this slide is the biggest changes in our blood pressure are going from lying to standing. So this becomes a really big concern, especially for senior patients who are getting up at night. They've taken their blood pressure medications at night. They've taken their, they haven't drank since dinner, any water, any fluids, and all of a sudden they're laying down, go up to stand up, and now their blood pressure drops precipitously. And that's when we see a lot of our falls, which is at night. So the big thing that I want you to understand is that there's a big change in blood pressure. If we can get to the next slide. No, that's okay. I can flip it. I can. I'm sorry. I'm going to grab these guys.
It's okay. I'm pretty self-sufficient, you know? Enter.
Okay, no, here, I'm back.
All right.
Sorry.
Okay. No worries. All right. All right, there we go. Oops. Let me see. Right here and then down.
Okay, perfect.
Okay. Yep.
So the definition of orthostatic hypotension means that there needs to be a drop of at least 15 to 20 millimeters of mercury upon standing. That's a pretty big drop. Naturally, just for you and I, if we were lying down and we went to stand up, our blood pressure would drop by about 10 millimeters of mercury. The most incredible thing is that when we stand, approximately 1,000 cc's of blood pools in our legs in order to keep us erect, which is a lot of blood. So when we think about, that's basically like a liter of blood. So when we think about that amount of change in our body that's required for us to stand, you can understand how in our older patients who are not drinking well and are on blood pressure medications, this can be so profound and it really leads to a considerable amount of hospitalizations. So that magic number that I want you to know and take from the talk today is 15 to 20 millimeters of mercury is really kind of the definitive. The other part that can happen when you stand is that your heart rate can also go up. So if there's a heart rate change of approximately 20, so if your heart rate was 65 lying and you stand up and now you check your heart rate again and now it's up to 85, then that can be linked to a symptom called POTS disease, where it's postural tachycardia syndrome. That's very common among young people. So so it has an exaggerated response. Almost your heart rate is overly responding to having to stand. So it's an exaggerated response. So there's two areas that we want to think about with orthostatic hypotension. One is the blood pressure portion and the other one is the heart rate portion. Go to the next slide. So as I kind of stated to you before, 500 to 1,000 mLs of blood kind of go into your legs every time you stand. And the process of standing is a very complex cardiac process that we take so for granted. You can go to the next slide. So the normal response that I kind of already alluded to is about 5 to 10. I do believe clinically, because of my experience in taking care of patients who have had pre-syncope, syncope, falls, dizziness. When we use this word syncope, it means that basically the patient's going to have a near fainting episode. So if they have had that, and if you feel any symptom, even such as mild dizziness, I would say that even if you haven't dropped that 15 to 20 millimeters that I kind of said is like the gold standard in order to make the definitive diagnosis, I still believe that you probably still have some level of orthostatic hypotension, and it's something to be looked at. You can go to the next slide. So The surveys have looked at many patients who have been found, and they found that approximately 25%, which means 1 out of every 4 patients over 65 has some level of orthostatic hypotension. And the cardiovascular health study that we looked at, 18% of subjects 65 years or older probably have it. So that's another, cardiovascular team that's also looked at it. And some estimates on hospitalization say 15 to 20% of hospitalizations could be related to orthostatic hypotension. So we can go to the next slide. So when I was talking to you initially earlier, a little bit about the process of the change in blood pressure that's required in order to get you to be erect from a supine position. What I wanted to kind of go through this slide because I think it'll help you understand how we do targeted treatments and how to understand, what the mechanisms are happening to help you, create a care plan for yourself or your patients or loved ones or family members that might be experiencing this. So the first step that happens is we want to decrease blood return to the heart. So a little bit of like kind of a cardiovascular anatomy kind of talk over here. But basically what you're trying to do is you want to pull the blood to the legs because that's where you need the strength in order to stand. So there's a decrease in cardiac output that occurs. The other thing is there's an increased pressure on vascular system. So it tries to increase in an attempt to try to get your blood pressure to stay as strong as we can, our sympathetic nervous system kicks in. So our fight or flight response, our epinephrine will then increase systemic vascular resistance, try to avoid vasodilation and constrict your superficial vessels. We talked about the sympathetic response, which is kind of related to this POTS syndrome that I was talking about earlier. So it's normal for your heart rate to go up when you stand because your body is trying to maintain as much blood pressure as possible. But if it's an exaggerated response, that's when we see that diagnosis of POTS. And then decreased cardiac output and decreased blood pressure occurs naturally upon standing. You can go to the next slide. So what are the big things that can cause a decrease of blood return to the heart? So we know naturally there's a decrease in cardiac output because they're trying to pull blood to the legs. So medications are really one of the biggest ones. I would tell you that there is a list of medications, which I think are later in the slide, that show all of the medications that can decrease your blood pressure. Obviously, blood pressure medications will do that, common sense, but there's other medications such as bladder relaxation medications, certain psychotropic medications that can decrease the blood pressure. So a great way to look at this in a very simple way is to do an inventory of your medication. Have your primary care see you and take a look at which medications could be affecting this. Infections. So infections are a source of all problems that we've seen, hospitalizations, risk factors associated with low blood pressure, high heart rate. The natural response to an infection is always to increase your heart rate. When the infection becomes further along in the process and you have a lot of bacterial or viral toxins circulating in your body, that can drop your blood pressure as well. Sepsis, which is a more severe form of an infection, kind of the next steps, which is going to get somebody into the hospital, obviously can cause this. Dehydration, one of the biggest ones that all of us on a daily basis are working on to keep our hydration status up, especially with the temperatures that we're seeing and all the warming trends. So really want to keep that hydration up. And then diuretic medications, which are a lot of the medications we use to treat congestive heart failure. So what can alter vascular pressure? So remember we talked about, so the first one we talked, the normal process was decreased cardiac output, lowering of the blood pressure, which happens naturally. But now how do we alter that vascular pressure? Remember we said that the periphery, our peripheral vessels will have to clamp down. So things that will limit that include obesity, tobacco use, which decreases the ability for your body to naturally respond to standing, dehydration, alcohol use, high sodium intake, and blood pressure medication. So if any of these factors play a role, it'll further decrease our natural ability to stand and have that reflex tachycardia that we're looking to have naturally. Go to the next slide. So what causes changes in cardiac output? That was the next one that we were talking about. So again, this is starting to sound very, I'm hoping you're getting these points, but starting to sound very common. So our common culprits, again, diuretics, dehydration, internal bleeding, vomiting, anemia, medications, and the postprandial hypotension. So I'll talk a little bit about postprandial hypotension. This is really underdiagnosed too. It's a little different than orthostatic hypotension, but I would say probably 20% of people, there's a transient drop in blood pressure 75 minutes after eating. Eating is one of the most complex things that requires a lot of blood supply to your stomach, to your small intestine, and then eventually to large intestine, and eventually to the colon. So by time you eat, so your lunch right now, which you're eating, will probably reach your colon somewhere about 3.5 hours after your meal. That's when it gets to the more distal part. But the initial part, which is about 75 minutes, is somewhere in that distal part of the stomach and the beginning of the small intestine. So in some people, there is a drop in blood pressure about 1 hour and 15 minutes after finishing eating. And that is a very common cause of falls that we can see, or feeling lethargic, or feeling fatigued, or feeling unwell after you eat. So that's something to definitely consider. And there was a number of studies that were done about this that I can talk more in the future about, or give you some recommendations of where to look for those. So medications, like we talked about. Anemia is another one that I really think is underdiagnosed and undertreated. So you can actually have a very mildly low hemoglobin, which is the way that we diagnose anemia. But the definitive way to diagnose anemia is actually to get the iron level and the ferritin level. So if your primary care physician is still feeling fatigued and you kind of don't really know if you're anemic, or you've heard that anemia can cause a lot of the symptoms that you might have, you really want to have your iron and ferritin levels checked. The ferritin level is a good indication of what your iron stores are. And the iron level will tell you really where your capacity of storage of the essential vitamin is in your body. So I would really suggest that that happen. I think untreated anemia has a big role in a lot of morbidity and mortality we see in our patients, and poor quality of life. So vomiting, the other one that I just want to talk about very quickly is, small amount of vomiting, especially in an older patient, can really lead to a really rapid drop of blood pressure. So if that is the case, you definitely want to get an antiemetic on board right away. So the Zofrans or those medications will make a big difference in really trying to allow the patient to at least keep the food in for a short period of time. Internal bleeding, which sometimes can go undiagnosed for a long time, like a gastric ulcer, a bleed somewhere in the small intestine. So all of these things should really be looked at in detail. If you have any concern of those, definitely bring those up. And as I think, as a physician, I feel it's fine when my patients advocate to me about what they think may be wrong. I don't think that that's ever a wrong thing to do, because I don't think anybody knows their body other than the person who's in that body. So, so this is the slide that I was talking about on medications. So a lot of the medications I wanted to talk about that, aren't the common ones that you may frequently think about. So some of the anti-anxiety medications can really have a big role, which obviously we know that there's such a growing need for assistance with anxiety and depression, as so much of our world has changed since the pandemic and so many of the restrictions that we're seeing. So you really want to think about any type of psychotropic medication, whether it's an antidepressant, anti-anxiety medication. The other one that is a big one is medications that dilate the bladder. So a lot of times you'll have a patient goes into the hospital, has a knee replacement, hip replacement, somewhere in their 60s perhaps. And what ends up happening is they end up needing a Foley catheter. They get started on them, they get sent to rehab, or they're at home and they can't get the Foley catheter out. So what we do as a clinical team is we start a medication that will dilate, the urethra, the ureters, dilate the area of opening in the bladder. And what that does is it has a profound effect on blood pressure. Think about what it's trying to do. It's trying to open up the airway. So as we open up the airway, it dilates, so it drops the blood pressure. And that is a big one. I actually just got off the phone with a patient family. I just had a patient that fell 2 times at night and was on one of these medications and had it started almost 2 years ago, after she came back out of rehab, after she had a hip replacement. So you really want to do a good, thorough review of medications, and your medications need to be adjusted and changed with time.
Dr. McKenna, so
Yeah,
was
sure.
that person still on the medication from
Yes.
having it 2 years ago?
Yes.
So that would be wrong then, right? I mean, normally, why would you stay on it, or
So
do you
what
stay on it?
happens, what happens, I find with healthcare is we're really good at adding on
Yeah,
medications.
not taking
and
off,
We're
yeah.
really bad at taking off. We think that, perhaps the patient is stable on it because the patient is doing well because they're on it,
Yeah.
right? That's not true all the time. Sometimes it is,
Mhm.
okay? But yeah, this patient had been on it, so it's very easy, when I take a medication off of a patient, I don't just take it off and hope that they're okay. I can recheck her kidney function, I can track her urine output. So there's definitely mechanisms where I feel empowered as a physician to be able to take off a medication safely.
Mhm.
And that's the big question, right? Is, are we able to take these medications off safely? And the answer is yes, with a good follow-up and good education. So the other ones that I really wanted to talk about are the vasodilators, nitroglycerin, used for patients who have angina, or any of the medications we use for pulmonary hypertension or erectile dysfunction, which are big, huge culprits. Blood pressure pills, which I kind of talked about, antidepressants, we talked quite a long period of time about, and medications for treatment of Parkinson's. Those ones are very big culprits, dopamine-based medications, which can really wreak havoc on this natural process. And believe it or not, some of the newer diuretics that we're using also can do that. So let's go to the next slide. So the way that I would say would be an easy tool for anybody to do to check if they're orthostatics, this is something that somebody can do if they have a loved one that can help with checking the blood pressure, or you can check the blood pressure yourself, is so you always want to go with supine, so lying down, right? Then sitting up, then standing. So you can do all three. You can check blood pressure during all three changes. So you can check your blood pressure when you're lying down in the bed. We assume that when you stand, there'll be a natural response of a drop of at least 10 millimeters of mercury. Or you can start with just sitting up. I would wait about 1.5 minutes between each change in position and see how your blood pressure and heart rate. Remember, you're checking both. And that's an easy way to look. So you would just write down what it was when you were lying down, sitting up, standing. You want to be able to check that. And I would definitely keep a track of that for multiple weeks to see if that's a growing trend that you're seeing. We talked already about taking a detailed medication list, prescription and non-prescription medications. I just want to talk a little bit about non-prescription medications. They really can have more dangerous effects than prescribed medications. This is often an area where the doctors don't really pick up on it. And this is one of the advantages that we've had working in assisted living, because we have to prescribe everything. Over the counter, non-over the counter, we prescribe them all as a clinical team because our team here can't give over the counter. So I would tell you, I have found so many times where my patients are taking Benadryl, or they're taking cough medicines, or they're taking an over the counter, an allergy medication that can wreak havoc on the body. So you really want to make sure that prescription and non-prescription medications are getting looked at and reviewed by your team. You don't have to call your doctor all the time. You can actually Google or look up the non-prescription medications, see what are the common side effects. If you're feeling ill or not feeling well on it, that's something that you can do, and then ask your physician if you feel like you need further, suggestions. So medical history of congestive heart failure, malignancy, diabetes, and alcohol use. So when we talk about alcoholism and we put that in this big broad spectrum of, somebody who's drinking heavily, even small amounts of alcohol in certain patients who are on different medications can have a profound effect. So you do want to see if that is related to any alcohol use. And then neurologic exam, sometimes this orthostatic hypotension can be the first symptom of what's going to come in the future as a neurologic condition. So I think the more empowered our patients are, and we are with our medical conditions, is something that we can be alerted of. They found that in about 25% of patients with Lewy body dementia, one of their first symptoms was orthostatic hypotension. We can go to the next slide. So the complications that we talked about, one of the biggest ones are falls, which for reasons that make sense. Cardiovascular health. This was a really interesting study. They found that actually if you're orthostatic, it's a predictor of future cardiovascular disease. So that makes sense, right? Because it's saying that somehow you have this abnormal response. Your body and your heart is not working appropriately. So I don't want you all to think you're gonna have heart disease. You have orthostatic hypotension. I have orthostatic hypotension, but which is mild, and I'm easily able to treat it with fluids. But I do want you to be aware that if that is something that you're seeing and realizing more often, it could be a risk factor for early cardiovascular disease. Cognitive impairment, this one makes a lot of sense. So if the blood pressure drops too much, we know that the brain is going to be the first to be protected. And the first that needs, the brain needs blood pressure and it needs sugar. Those are the two things the brain needs, and it can't go long without either of those. So what we have found is that it can be a risk factor for future development of dementia. So hypoxia in the brain not getting enough blood, these cells now starting to die internally in the brain because that blood pressure is not getting to where it needs to be in the brain. And then others that we talked about, they can be disabling from a quality of life. You can get really scared and you always feel dizzy or like you're going to faint, or having any symptoms of what orthostatic can do can make you feel nauseous for a short period of time too, because that change in blood pressure is profound on the body. So those are the other areas that we would look at. On the next slide. So treatments. This is one of my favorite parts about orthostatic hypotension is there's actually treatment. So one is obviously something we can all do, which is a behavioral, environmental, and natural thing, which is fluid intake. That makes common sense that we would increase fluid intake. One of the big ones that I really like is if you also tend to have lower sodium levels or lower chloride levels, which you can see when you review your blood work. That's an indicator that you're dehydrated. So that's very easy to treat. Gatorade really provides a lot of electrolytes, or any of those electrolyte filtrants are totally fine, but they also have a big role in being able to really improve your vascular fluid. So we talk about non-pharmacological. So this is this left part of the slide. So it says, non-medication based treatments, right? So increasing fluids, medication review, physical therapy, which can learn and teach you how to better adjust to the orthostatic changes, and then treatment of anemia, which I kind of alluded to earlier, can be so common and so underdiagnosed. So when we talk about pharmacological treatments, so midodrine, which would be the first FDA approved drug, is a pretty safe medication unless you have pretty severe cardiovascular disease. That's one that I have to really kind of watch on my patients who have severe cardiovascular disease, because it can increase your pressure so much that it can cause some angina and chest discomfort. So that's one thing you have to definitely be careful with midodrine. But we usually started at like 5 milligrams twice a day or even once a day to see if there's a response. And then you can up titrate it. Our patients who are on dialysis who have profound changes in blood pressure, high, low, from 210 down to 80, we see this all the time. Hypertensive before they go to dialysis, hypotensive after dialysis. So we can bring this up to almost 25 milligrams 3 times a day in those patients. So just putting it into range for you, starting a low, slow dose, there's no cardiac disease, 5 milligrams once a day, 5 milligrams twice a day is a really reasonable option. The next one is droxidopa, which I don't use very much because it's a dopamine-based drug, but it is FDA approved, and there is some new studies that patients who are refractory to the midodrine, so let's say I start them on midodrine, they're still orthostatic, they're not doing well. If you add the droxidopa with the midodrine, it's really been shown to do that. And you can actually use a lower dose of the droxidopa, so that way you're not getting such a high dose of the medication, because the two of them are working better together than one separately. So fludrocortisone is a really common one that I use all the time. It's kind of like it's kind of like a steroid-based, aldosterone-based medication. It's a natural hormone that all of us have. You just boost up the levels of the natural hormone, and that will really help. So this tends to work really good in men, especially if they have hypoaldosterone levels. It will help to increase their aldosterone levels. So that one works really well. And then the treatment of anemia, like we said, which is with iron and erythropoietin. So iron you can take, which is an oral iron. You can take a high quality oral supplement that doesn't have a lot of GI side effects. But erythropoietin is a really good medication for a person who has advanced chronic kidney disease. This is dosed and handled by the nephrologist, and it stimulates the bone marrow to produce red blood cells. So sure, that was a lot of information. And I talk quickly.
You did talk, that's okay. So I do.
We have like a dictionary.
Yeah, I know.
Well,
So I do want to open it up for
Yeah.
questions, right? So before I do that, because I'm going to actually take the screen off. So we're going to do Q&A, but this is for those of you who are online also are in person. So quarterly, we have an After Dark series to our Lunch and Learn, which is going to be next month. So it's Punch on the Patio. So it's a networking event that's going to be on August 17th. It's a Wednesday from 4:30 to 6:30. So before I take all this off the screen, because I worked so hard on my slide, I wanted to make sure that I let you guys know. So write down the date. Yeah, I see somebody jotting it down. This is perfect. August 17th, 4:30 to 6:30. And then what I'd like to do is open it up for questions, but I'm also going to make sure everybody online, and I could actually get off of mine now. So we're going to open it up. If you guys can hear me online, and I see nobody's got their cameras on, but if anybody has any questions. All right, so Kathy.
Can't remember exactly the wording that you used, though, but it was that one of the diagnoses that you said is like 25% of the people get that canna deal or something like that was on the bottom. I was like, how do you diagnose that? The eating one, that one.
Oh, yeah.
Postprandial
Yeah,
hypertension.
that's the one.
That one, so the postprandial hypotension, that one, you just have to check your blood pressure about 75 minutes after.
So if
eating.
somebody kind of notices it, that's when you would just say
Right,
that
Right.
might be something. And what would,
the
is there,
symptoms be?
or what would the treatment be, I guess, kind of just
Well,
make sure they wait? It's just something that their body has to go
Well,
through.
the other thing that, I mean, a simple one is, once knowledge is power,
Yeah,
right?
yeah.
So once you know that you have it, I
Mhm.
think the idea is when you increase your fluid intake after the meals, that would be big, right?
Mhm.
And then the other thing is when you're standing, you have to do it in a slower process than which we do it,
Mhm.
right? So I think it has to be standing, waiting at least 15 to 20 seconds, make sure that your blood
Getting
pressure hasn't
lightheaded.
dropped too much, and then slowly go. But there's certain foods that can potentiate that, so I think a food log would be good, and then, you can look it up, there's a lot of data on postprandial hypotension. There was a number of studies that were done about 15 years ago on it, but I think the knowledge is the biggest part,
Then they would.
Mm.
understand
and you would
too,
make
right?
lifestyle modifications, right?
Great, thank you.
Georgia.
So what is the proper testing for iron deficiency?
So it would be an iron level, TIBC, and the ferritin level. So those would be the three that I would start with.
Iron,
Iron level, TIBC, and then the ferritin level, FERRITIN. So those will kind of give you, it'll tell you all the different kinds of anemia. But that's specifically for iron. I usually do like a methylmalonic acid, which looks at the B12 level, and the vitamin, and the folic acid, which can play a small role in different types of anemia too.
because I have a patient with severe hypertension, almost like 40 to 50
Drop.
Wow.
drop.
Wow.
And now she said on Tuesday, oh, I'm gonna feel better because I started on iron.
Right.
So I was wondering if no new medications iron.
That's profound. I mean,
Yeah.
this patient, if they don't have heart disease, I
Oh,
would
she
definitely,
has heart problem.
she's heart
She
problem.
has heart problem.
So
too.
she probably has some level of kidney disease too.
Yeah.
Because, if you have heart issues, you're gonna have poor perfusion to the kidneys. If she's iron deficient, you really need to know what kind of iron
Yeah,
deficiency
this
she
is
has. That's a whole nother
Okay.
topic.
Yeah, if there was a proper test. Yeah.
She needs the proper testing, but the good thing with the ferritin is it'll tell you if it's anemia of chronic disease or straight iron deficiency anemia. It'll give you the answer on the blood work. Yeah. So you'll be able to determine that.
PCPs tend to do what you just said, or do you have to kind of plod them along?
I don't know, it depends.
Yeah,
It depends. I mean, for me, because my patients are so complex,
you just do it,
yeah, and I think should be a good standard first test to do.
Audrey, you had a
I have a
question.
question. Are you seeing a lot of different cardiac issues after COVID? Because I have them.
No?
So ironically, rapid heart rate, things like that. Are you seeing a lot of
We're
your
seeing a
patients
lot
with
of
that?
We're seeing
And
a
I
lot
almost
of
felt
that.
like the cardiologist was like, yep, let's do these tests, but it'll get better. I'm like, okay.
No.
Mm.
I mean, I
But-
wouldn't be happy with that answer. I mean, that's the
I
scary thing.
know.
So we are seeing, I mean, I have a couple of my colleagues who practice in other states and everything. So we're seeing this across the board, right? Not just in the state of Massachusetts. I've had colleagues in California, Texas, Massachusetts, everywhere that are seeing very similar symptoms. And I don't think we really have the answers yet. a lot of the patients who went into the hospital, just to let you know, with COVID, because they were considered to be more severe, they are walking out with an ultrasound with the heart, an echocardiogram with the heart. So, we're seeing rare, cardiomyopathy starting, so inflammation of the heart, tachycardia. We're seeing some physiological changes, electrophysiologic. So we're seeing a lot of arrhythmias that we didn't see before. It's very hard right now to really know. I don't think any of us can say with certainty that we know enough about it at this point. There's well documented cases of cardiomyopathy. And like I said, I think an ultrasound of the heart is the way to go with an electrophysiologist, and probably a Holter monitor is the way I would go.
I did have all of that, but
Yeah,
I'm just curious if you're seeing a lot of it, but yeah,
we are.
I know.
We
And that's
still are.
status post having COVID. You
That's
mean, not
status-
just
Like
COVID,
after, it's
after you,
after COVID.
yeah,
like
after
it's
you've had
post-COVID.
COVID, like late
Part of
COVID.
it is considered to be maybe some of the COVID long hauler
Lungs,
symptoms.
yeah.
I would still say that, when your body is recovering from a new novel virus like that, you need to give your body time. And we all expect that our body is going to recover in a week or 2 weeks. That's not the way the body works. It can take 6 months, a year and a half, 2 years. The other thing is, we need to increase our physical activity. So many of us were just not active during COVID. It's just such a huge change on our body in so many ways. That also had a profound effect. But I am seeing it. Yeah.
Who else has a question? Anyone else? In the room, we'll do in the room first. Anybody in the room? And then how about anybody online? I do see, Josie did ask if we were gonna be able to share the slides.
Sure, yeah.
Oh, that'd be
Okay.
good.
So Josie, the answer to that is yes, I'll be able to share the slides. I have your email. And then anybody else online have any questions for, okay, perfect. She gave a thumbs up. Okay, good. Anybody online, any more questions for Dr. May? So we are lucky enough to have Dr. May as our on-site physician here at Ruth's house, which makes it very nice for us. Yeah, we're very lucky to have her here. How long has it been since you?
Oh my gosh, I think it's been probably 3 or 4 years
Yeah.
now, right?
Yeah,
I think I remember when I was here giving my introduction of what we were planning and hoping to do in the community.
right,
So it's really great that we've been able to be here and,
Absolutely.
yeah.
Perfect. I really appreciate everybody. And since we have a little bit of time, I was thinking we could go around the room, right? And we could actually just introduce ourselves and just say who we are.
I figured you already did that. I missed all that.
No, you didn't miss that, Kathy. See, you didn't.
Go ahead, be the first one.
What I'll
Sorry,
do,
I'm late.
yeah, totally. You could, so you guys hang on online.
Oh, you want to do them first?
Randy, are you there? Nobody's got pictures online, so I think you guys are there. I don't know really though. Here's Randy. All right, you could unmute and you could say hello to everybody. We've got somebody from out east over here, so they'll know who you are.
All right, hi, good afternoon, everybody. I am coming to you live from my dining room in Hull, Massachusetts, right on the coast, and I represent a primary care practice that only does house calls, and it's called Boston Senior Medicine, and our entire footprint is the east half of Massachusetts. So we bill insurance, healthy, sick, or feeling blue. This primary care comes to you. Thank you.
Nice,
Perfect commercial.
very nice. Does anybody else online want to say hello or where they're from? We've got crickets.
Maybe I'm trying to get off.
All right. All right. Well, then we'll start with you.
Yep,
Kathy,
okay.
yep.
First, I want to apologize. I'm so sorry. Trying to get one place on time is never easy. It's like one of the things I do is home care. So I work with the medicine home care. I have been with them 20 years. I'm bragging now because I just feel like it's such a milestone.
Yeah.
We're a skilled home care agency. We are nationwide. Our local office here is in Agawam. We do work in a lot of the assisted living that Dr. May works in. I'm so happy to have known her and all the working she's doing with our geriatric population. And that's our specialty, geriatrics. So, but our office is out of Agawam, and I'm a care transition coordinator. And then my background is physical therapy, so I know a lot of the things that Dr. May was talking about with their patients. But happy to be here and glad that we're having these series again. So thank you.
Perfect. Absolutely. Glad you're here. Georgia, you want to say hello?
My name is Georgia. I'm a physical therapist. I worked for DM for many years. I was my job, my training was orthopedic and sports medicine. But after so many years, I went to per diem forget, and I love it very much. And that's amazing.
Nice.
I'm so lucky to work with all of you. It's wonderful. It's just good to work with people that have a smiling face and a familiar,
And that care.
familiar face. It's all about compassion. That's
Yeah.
really
And
the
I
bottom
think it's very
line.
important when we call the office, immediately we get response. I mean, good communication, and there's so much about the medication myself and this and that and the other. So I think that makes a good doctor and a good team of taking care of people. So
Dr. McManus, how many, what do you call, the people under you do you have?
Oh,
How many now?
yeah,
Yeah,
my
PAs
physician
and
assistants and advanced level practitioners. So we have 6 right now. One of them is per diem and we're hiring a new person. So it's exciting. We have 6 PAs and MPs.
Yeah.
It's kind of sprinkle of both. And then we have 3 office staff members that kind of handle our triage and our administrative needs. And then we have 2 staff members that do chronic care management, which is a new preventive care program I was talking to you about. And we do have a social worker also.
Wow, you've
Yeah.
really grown great.
Yes,
Oh,
yes.
I was gonna ask you how many you get everywhere.
She's cloning herself.
It's an interesting staggering of the schedule. Believe it or not, I'm the one that staggers the schedule because if I didn't, then nobody else would know how to do it. So it's probably one of the best, my best skills. is the
Do you get
schedule.
into all your buildings at some point? I know
I
you have.
try to, it's been tough because I have some buildings where my PAs and MPs are there much more than I am. But I would say that usually within every 3 months, I'm usually
At
seeing,
least something.
I'm seeing the patient. And some of the patients I completely see more than the PAs. So it just depends. But I would say most of my buildings are pretty much, I cover the most in terms of even all the PAs and MPs. But it works out great. I wouldn't be able to do it without my team. They're fantastic. I really have good providers. I really, really do. I do. They're just so committed to the team. They work 5 days a week. They're on call on the weekends. But we share the responsibility. They're really amazing. I'm just so fortunate to work with them.
And I think they keep mixing, so you have a social worker, what job is she? I understand
Well,
what the
social,
MBA are doing.
especially after COVID, what we found was that we were just referring for depression and anxiety and different placements and people's level of care that needed to be changed, So our social worker does both. She does psychotherapy and she does triaging for us, because what we're finding is, sometimes we really do have to admit patients to Jerry psych. They're just so debilitated and down, and we want somebody who can streamline that process and have that connection with a Jerry psych hospital that offloads that responsibility off of me and the PAs and the MPs, and then that social worker can serve as a conduit for the families and provide them the support they need there as well.
Great. Good.
Yeah.
Good to
I
know.
ful like every physician practice should have a social worker if possible.
Wouldn't it be nice?
Because
It would be
there's
nice.
always that
Mhm.
social component to everybody's
Mhm.
life. And I look at my life and managing kids and a family and, how are you handling that? That should be a question that, your
We don't
doctors
handle
ask,
it well.
right? We don't, so something's always got to give. One week you're like on top of it, on the right side, and the next week you're like on top of it, on the family side, but
Something's got to give.
Yeah.
Called a nanny.
Yeah.
It was great to know that you have that
Yeah,
resource.
I think that resource really we should increase those supports across
Yeah.
the board. Yeah.
We need
Yeah.
them, just like everything,
And
there's not enough out there as
And
it
for
is.
the families to navigate through the healthcare system, because, sometimes they don't know what level of care they need, their loved ones, and we want to be able for them to have somebody to really be able to look at that situation and say, I think they're at a different level of care.
Mhm.
Perfect.
Like you said, it helps you guys. I'm sorry.
Yeah, no, that's okay. I just want to get,
Yeah, get
actually, go ahead.
everybody.
Yeah.
Hi, my name is Laura. I work with Hanger Clinic. I'm one of the office administrators, and I also run our local Empower Empathy Support Group. We do orthotics and prosthetics, obviously, and our local office is located in Springfield, so it's actually just 10 minutes down the road. We're very accommodating with house visits, everything, resident visits, so let us know if there's anything.
Perfect. All right, Audra.
Hi, I'm
Audra, I'm from Comfort Keepers. We have an infield location in Long Meadow, Massachusetts. We do have the VA contract in both states. We do private duty home care and safety equipment options. And I am a social worker. So I do all the case management and marketing and everything like that. But at our building, I actually have a little library of resources. So if anybody wants to give me their info, I'm always like, so many of our clients are like, oh, where would I go for, medication? Where would I go for this? So I always have that library, and I think it's so important. So, and also if we can't take anybody, I refer them to other home care. So that's really nice. We do. But it's nice to be there, and thank you for having me.
Absolutely.
I can say that I've been,
How long have you been there? Yep.
caregivers for like 21 years.
You beat me.
now. That's long.
I've known her that.
But I also do music programs, so I think I love my company, but it's flexible, they're music and stuff, but we do supportive home care, anything from transportation to 24-hour care. Georgia just called me. We needed a little bit of transportation, a funky little complicated case, but things like colonoscopies and procedures that require a person to be there and drive them home. So it's interesting, small projects, cases are large ones, and I kind of consider myself a problem solver. Because like you're going to get somebody to the right person, right? We have a VA contract and come up their lines. Don't work a lot with doctors, because doctors don't seem to think of us first. They think of skilled nurses first. So we find it's the social workers from the skilled companies who are thinking beyond that. So I'll tell you later the doctors. Oh, good. But you know what? You have to work with your competition. You learn. You definitely learn. But somebody doesn't need home care, maybe they need the best assisted living.
Yeah.
Or
It's all working together.
and it's all dependent upon that person.
Mhm.
Do backflips and you still don't work with the person, but.
Right. Andrew, you want to just say hello?
Yeah, hi, I'm Andrea, currently the activity director here at Ruth's house, and as Mary had mentioned, transitioning into the director of marketing position.
Oh, good for you.
Yeah.
I'm really happy. I'm excited about it.
We are very excited about it as well. Yes. Susan, you want to say hello?
Susan Halpern, Vice President of Development here at Georgia Life Care. We're a nonprofit, so we rely a great deal on community support. And we love having events like this that bring the community in and so that we can showcase the kind of services that we provide. So thank you for coming. It's exciting to be here in person and also know that people can access it virtually.
Yeah. I think we did okay with the hybrid. I don't know. We'll see. Terry, you want to say hello?
I'm impressed. I'm Terry Halliday. I'm with Legacy Westchester, and we're sort of the parent company that has the good fortune of working with JPS Westchester and the team here. Andrea talks about how excited she is. We're truly excited because the changes in this building are because of the success that they've had in the current roles and giving them an opportunity to grow within the organization. In addition, so I work on strategy, and I think my most primary job is other duties as assigned. So every day is a new adventure, and that's really wonderful. I had the opportunity to try to convince Dr. Paul to come here and work with us in the building. It's been a wonderful success story.
Yes.
And I learned a lot and gave you presentations, so thank you very much. And I also chased Mary Ann around for about a year and a half. to convince her to come back.
That's true.
So, yeah. And I hope that she'll tell
The
you
circle of
friends
life,
that
right?
we'll get
Yes.
together again. So, thanks.
Nice. Absolutely. Dar.
I'm Darlene Warner. I'm the registered director here. I was actually here 4 years ago. For 4 years, took a break,
Yeah.
and then Mary Ann decided to come to head.
I knocked on her door. I did. Right. Yeah, actually, yes.
And I'm thrilled to work with Dr. May. And,
Yeah.
I think worked with that even in the building yourself
Oh,
personally. for the
I
past
know,
couple
I
of weeks.
know. It's great. You'll be seeing me a lot. I'm gonna have a new person coming on, a new MP, and I'm excited use your building too as such a teaching site, because you are a great building here.
Oh,
It's very calm when I come in, things are handled, and the nursing staff and the staff here really are very hands-on. I'm really impressed. It's a great place to be.
Thank you.
nice, nice. Kelly?
Hi, I'm Kelly Ambrosio. I'm an elder law attorney in West Springfield. And I've worked with elders in the past and currently that reside here in other facilities in the community. Which will come out and meet other professionals and other people in the space.
Perfect, thanks for being here. Lisa?
I am attorney Lisa Bove. I'm from West Springfield and I do elder law and estate planning also. And I've been doing this for about 27 years now. I've also had the privilege of working with Dr. May on some of my clients in the facilities. And she's been wonderful. So I wanted to be able to say I met her in person.
My pleasure, my pleasure.
Nice. Sarah?
I'm Sarah Pimos. I'm with Inhabit Home Health, the Public Home Health. I'm still nursing, PCOT, I'm area manager.
Nice. So what I normally do is I have raffles, right? So everybody online, I don't want you to think that you're going to lose out. So I really was torn, like, what do I do? What do I do? So I have two prizes and I have a little, if anybody's been on my Lunch and Learn, I usually have the wheel and I actually press it like Randy, like Gordon's. So I had to do yours first because I couldn't do two at once. So basically, Randy, you were the winner on your side of things. I know. So congratulations. You're just going to miss out on the local gift. So yours is a Starbucks gift card. So I'll send that to you. All right. Oh, I think she froze. She looks very intense. She looks very intense. All right. So I hope you can hear me, but you've got a Starbucks. Oh, there we go. Yep, a Starbucks
Thank
gift
you.
card. Perfect. And then for the folks here, I actually went to a new shop, and I don't know if anybody knows what the Grady shop is or
What?
Grady.
What?
Grady, Grati. It's short for gratitude. Kelly Partridge is the owner. She only had an online store and a presence, and now she just opened brick and mortar last Friday. It is a phenomenal little shop. When I was there buying my things on Boston Road in Wilbraham, when I was there, I actually decided to buy 2 gift cards.
I
one
just
of
want
which I'm gonna wrap
a
up.
Starbucks card.
And it's a great little shop if you haven't been there. So I don't have a wheel. I had to do an app on my phone. So it's got all your names here. So I just go choose. So hold on. Laura. Okay, perfect. And then wait a minute. I get to, let's see if it says it. Say name.
Laura.
Oh, there it is. Usually it's like confetti and, but it wasn't as fun as the other one. You're welcome. Congratulations.
My first lunch series.
Oh, perfect. You will absolutely love the store. It was phenomenal. What?
Presents or coffee or what?
So for the Grady shop,
Yeah.
clothing, women's clothing. It's a women's clothing boutique.
Where is it now?
It's the Alpha Oil building on Boston Road in Springfield. It's literally, if the sign says Alpha Oil with all the things, she's straight ahead. It's beautiful. And the stuff is very affordable. Like it's a $25 gift card and you're literally going to be able to buy something for $25. And it's really pretty and nice. And you know what I mean? It's not like some of the boutiques are like really
Yeah.
expensive. 25.
Yeah.
They have
Yeah.
The left side or right side?
Um,
I'm gonna go.
So if you were, so
I know.
You said you're Wilbraham or Springfield?
Wilbraham,
Oh,
Boston
Wilbraham.
Road, Wilbraham,
I know
same
where
side
that
as Post Office Park.
Oh, okay.
Same
Okay.
side as Post Office Park. And then
Yeah.
if you're looking at the building, Alpha sign is going this
Yeah,
way.
yeah, okay.
Grady shop is dead center.
GR.
ATI. It's short for gratitude. It's short for, she's got a lovely story. Yeah, she's,
I like that.
yeah. And she's got a really good story as far as how she actually started her business and everything. It's very inspiring.
Nice.
So, yeah.
And I love that you supported them. That's great.
Yes,
Yeah.
all about local. I'm all
Yeah.
about local women and local stores. So everybody online, I'm very happy that you guys were all here. Thank you very much for joining. I will make sure I send all the slides out from Dr. May, so thank you. And everybody here, thank you very much. Be sure you take like a bag of chips or something for the road. I think there's also, there might be something, I think there's cookies back there,
You
right?
can actually take
Yeah,
this plate, right?
You can take the plate. Yes, you can. Thank you, everybody. Have yourself a great afternoon.